Hi everyone, I hope you're all doing well. For my final project, I decided to do it on biliary atresia. For this exam, you will use a 5 to 8 megahertz curvilinear transducer, and with larger patients, the 3.5 megahertz probe may be necessary. You will lay your patient supine. Left posterior oblique or left lateral decubitus may be a beneficial position. For your scanning protocol, you may be completing a right upper quadrant exam or a complete abdomen exam, depending on what is ordered. For your grayscale, you will acquire sagittal and transverse liver protocol images, making sure to measure the liver and assess the echo texture. Acquire sagittal and transverse images of the gallbladder, making sure to measure the gallbladder length and the gallbladder wall. You will acquire sagittal and transverse images of the portal hepatis, making sure to measure the triangular cord if seen anterior to the main portal vein. For your color Doppler, you will acquire a main portal vein, hepatic artery, and liver subcapsular flow. Some information about the pathology. Biliary atresia is a congenital biliary disorder of the intrahepatic or extrahepatic ducts. The most common cause of cholestatic jaundice in neonates and infants is biliary atresia. It is more common in males, usually presents at 3 to 4 weeks of life. The baby will present with jaundice, hepatomegaly, dark yellow or brown urine, pale or clay-colored feces. Experts don't know the exact reason of what causes the biliary atresia. There is research suggesting that it may be acquired in the womb or after birth. Some of the causing factors are liver and bile duct problems when developing in the womb, infectious due to certain viruses, immune system problems, changes in genes. Biliary atresia is not passed down from a parent. Hepatic function blood work will show elevated serum transaminase and bilirubin levels. Sonographic findings. There are 4 sonographic grayscale findings of biliary atresia involving the following. 1. A small gallbladder measuring less than 1.5 centimeters in length or an absent gallbladder. 2. Irregular wall or irregularly shaped gallbladder. 3. Following feeding, the gallbladder does not contract. 4. A triangular cord sign. This is an echogenic triangular or tubular structure measuring more than 4 millimeters in thickness, anterior to the main portal vein and the porta hepatis. This has a sensitivity of 73 to 93% and specificity of 96 to 100% for diagnosis of biliary atresia. Doppler findings are the following: enlarged hepatic artery, increased hepatic subcapsular color flow. Here are some images of the pathology. The brown arrow is pointing to a small gallbladder, which is measuring less than the 1.5 centimeters in length. This one here is measuring 0.80 centimeters in length. In these images, we can see the arrow pointing to a echogenic triangular structure just anterior to the main portal vein and the porta hepatis. Differential diagnosis. The most common differential diagnosis is neonatal hepatitis. It is very important to distinguish between the two. Neonatal hepatitis is managed differently than biliary atresia. Some of the least common differential diagnoses are Corelli disease, Alagille syndrome, bioplaque syndrome, and lipid storage disorders. Prognosis and cure. Biliary cirrhosis can develop if not treated. The Kasai procedure is the first treatment for biliary atresia, but it does not cure it. The successful procedure will slow down liver damage, delay complications, and patient will no longer have jaundice. Complications may happen, such as cholangitis. Antibiotics may be prescribed by the doctor. The success rate may look a little bit different depending on the age of the infant when the procedure is done. Infants under 2 months have a success rate of liver function of 90%. Infants of 2 to 3 months have a success rate of liver function of 50%. And infants after 3 months have a success rate of liver function of less than 20%. A liver transplant may be needed if biliary atresia leads to more serious problems or there is a failed Kasai procedure. Most children end up developing complications and end up needing a liver transplant down the line. As for prognosis, more than 80 to 90% of infants will survive to adulthood. Here I have attached a video of the Kasai procedure so you guys can see how this procedure is done.
In patients undergoing resections of the bile duct, the biliary reconstruction is most commonly performed with Roux-en-Y hepatocujuginostomy. This technique video will describe steps in creating a roux limb, followed by anastomosis of the roux limb to the common hepatic duct. To create the roux limb, the jejunum will be divided about 15 to 20 centimeters downstream from the ligament of Treitz. The proximal section is called the afferent limb, and the distal section is called the efferent limb, which will become the roux limb. A length of 40 centimeters of the efferent bowel will be measured distal to the cut end. The afferent limb will be anastomosed at this point in an isoperistaltic fashion. The roux limb will then be brought up in a retrocolic and retrogastric route and anastomosed to the common hepatic duct to re-establish bile flow. The anastomosis will be performed with interrupted sutures, with knots tied on the inside for the posterior wall, and with knots tied on the outside for the anterior wall. In patients
Here's just my works cited page where I got all my information from. I hope you guys enjoyed my presentation and I am excited to see everybody else's presentation.